going to talk about autonomic dysreflexia today, and this can be observed in patients with an upper spinal cord injury, usually above the level of T6. But autonomic dysreflexia is also known as autonomic hyperflexia, which means that there's an overactivity of the autonomic nervous system. This overactivity causes an abrupt onset of excessively high blood pressure. And the people that are at risk, again, are those that usually have a spinal cord injury at or above T6. Autonomic dysreflexia can develop suddenly and is potentially life-threatening and is considered a medical emergency. If it's not treated properly and correctly, it can lead to seizures, stroke, and even death. Autonomic dysreflexia occurs when an irritating stimulus is introduced to the body below the level of the spinal cord injury. For an example, an overfull bladder can be a noxious stimuli to a patient with a spinal cord injury. The stimulus sends a nerve impulse to the spinal cord where it travels upward until it hits the roadblock of the lesion of the spinal cord injury. And since the impulse cannot reach the brain, a reflex is activated, and a reflex is activated that increases activity in the sympathetic portion of the autonomic nervous system. This results in spasms and narrowing of blood vessels, which can cause a rise in the blood pressure. Symptoms that you'll see in these patients with autonomic dysreflexia: they'll have a pounding headache, they'll have the goosebumps, they'll have sweating above the level of the injury, they can have nasal congestion, their pulse can slow, they'll become bradycardic, they become restless, they have the hypertension, usually greater than 200/100, they start having flushing, nausea, and they can even get cool, clammy skin below the spinal cord injury. Treatment for autonomic dysreflexia, first and foremost, is to get them in a sitting position. That's priority. And then you want to worry about relieving the noxious stimuli. You want to find what it is that's causing the pain that they don't necessarily feel and relieve that problem. Some of the causes, again, can be anything from the hyperextended bladder to bowel impactions. It can even be skin breakdown if they have a bed sore below the level of the injury. Even ingrown toenails can cause an noxious stimuli on these patients. There's also two charts in your book, 45-10, which are features of autonomic, or key features of autonomic dysreflexia, and the 45-11, which are interventions, immediate interventions for a patient with autonomic dysreflexia. Some facilities have even instituted a protocol for their spinal cord injury patients because of the risk for autonomic dysreflexia, and this is just an example. And if you notice down under medications, you note that they use lidocaine for the insertion of a Foley catheter, and that's because we don't want to introduce any more pain or stimuli if they're already having an autonomic dysreflexia. We don't want to introduce another stimuli that can increase their blood pressure. And then there's a short video on this also.
Hi, Dr. Spine here. Today we're going to talk about a complicated subject, autonomic dysreflexia. What it is it's a rise in blood pressure that people with spinal cord injury get when they have a pain stimulus somewhere below their lesion. So autonomic dysreflexia as a condition is first signaled by very subtle symptoms. You may notice an increase in the tightness of your spasticity. You may notice goosebumps. Piloerection is what it is. You'll be sweating. Then, as the pressure goes up, you may get a pounding headache. And that is the sign that the blood pressure is going way up. The emergency is evolving. As time goes on, you may even get worse. You notice, you signal the word, other people are here, you could end up at the doctor. These people are frequently clueless. They have known nothing about it. That's why you have to know. You have to tell them what it is, how to treat it, what to look for, because this could save your life. So the question is, why is this happening? Well, it's a hyperactive reflex. Like when we tap with a hammer on your knee, it jumps. The same with the pain stimulus. Let's use an example. Ingrown toenail. Insensate below the lesion. Don't feel it at all. But it's sending a pain stimulus to the spinal cord. That pain stimulus comes in, the sympathetic nervous system goes crazy. But there's no message getting past the lesion up to the brain that says pain. The brain can't get a message down to kind of modulate the response and kind of calm it down to a lower pressure. So as a result, it escalates. There's a lot of reverb there that drives the pressure up. The first thing you do is you sit up straight or get someone to get you in that position. They get your head high, and that lowers the blood pressure as much as we can as to the head. The next thing you do is you look for a cause. Now, the most common area of cause for AD and spinal cord injury is bladder. If it's not the bladder, it's frequently the bowel. How long has it been since you've had a bowel movement? Then you need to think about other less common signs. Let's say you're at the doctor and you're looking for those. Well, you look at the skin for skin breakdown. You look for evidence of irritation. You look for rashes or burns. In women, menstruation itself, labor pains can cause AD. You also can have any intra-abdominal emergency causing AD. So you tell your doctor to look for those. We hope all AD episodes resolve great for you. A big part of it is going to be your own knowledge of the condition. And as always, take care of yourself and those around you. Until we see you next time.